and welcome. I'm Peter Igaz, and thank you for the introduction. And I also thank the Endo-ERN network for giving me the opportunity to make this webinar on this fascinating tumor, the pheochromocytoma. Some general features of pheochromocytoma are listed here. It is a rare tumor of chromaffin cells, rather rare, as you can see in the incidence and prevalence values. Most of pheochromocytoma is found in the adrenals, and 15 to 20% are extraadrenal. These are called the paragangliomas. The prevalence of pheochromocytoma in hypotensive patients is between 0.2 to 0.6%, and almost 4 to 5% of all adrenal incidentalomas are represented by pheochromocytoma, so this should be taken into account. Incidentaloma as a tumor of the adrenal that is discovered accidentally by the suspicion of other disease. There has been a previous 10% rule, that is 10% of pheochromocytomas are found in children, 10% are malignant, 10% are bilateral. Some of these 10% is still valid. For example, the malignancy is between 10 to 15%, but it can be 40 to 50% in abdominal paragangliomas or in some hereditary forms. And there is one very special feature of pheochromocytoma, and that is the heritability, and that the previous 10% hereditary has already been changed, and pheochromocytoma seems to be the human tumor with the highest heritability of all tumors. About 40% of all pheochromocytomas are associated with germline mutations. This is an exceptionally high number, so that explains why genetics is so important in pheochromocytoma. And there is one other major feature of pheochromocytoma, that histology cannot give information on malignancy despite intensive efforts. So the diagnosis of pheochromocytoma is clinical, that is the presence of metastases. Certainly there are advances, for example, these scores that are called the PES and the GAP scores, and novel data show that these have quite good negative predictive values, but still we cannot establish the diagnosis of pheochromocytoma based on histological analysis. We have to follow up patients, and if we see metastases, then we can establish the diagnosis of malignancy, or better to say metastatic pheochromocytoma. This figure shows the biosynthesis of catecholamines, as these tissues are catecholamine producing or tissues. The last step is catalyzed by this enzyme PNMT, that is phenylethylamine methyltransferase, and this has a special feature, as this PNMT is only expressed under high local glucocorticoid concentrations, and there is only one site in the body where this high local glucocorticoid concentration can be seen, and that is in the adrenal, and that explains that the last step, that is the conversion of noradrenaline or norepinephrine to adrenaline epinephrine, can only occur in the adrenal. The typical features of pheochromocytoma are seen in adrenaline-producing tumors. So in non-adrenal pheochromocytomas, in paragangliomas, the typical clinical features of pheochromocytoma is often absent. We will discuss this a little bit later. Just to begin with a case to illustrate this tumor, a 46-year-old woman who complained of sudden attacks for many years, in fact about 10 years, and had several psychiatric outpatient consultations. She was also always considered to suffer from some kind of panic attacks, and therefore anxiolytic therapy was proposed. During an attack that fortunately took place at an internal medicine consultation, a blood pressure of 300/150 millimeter mercury was measured, and the ECG showed ischemic signs. After that, the diagnosis was not that difficult, because there are few clinical cases where such high blood pressure can be observed, and pheochromocytoma is one of them. An abdominal ultrasound showed tumors on both sides, and then the suspicion for bilateral pheochromocytoma was established. I will discuss the hormonal workup a little bit later, but as I think that most of the audience has some experience, I would like to share these hormonal results. The chromogranin A was very high, that's parathyroid hormone, a little bit elevated, and she also had a mild hypercalcemia. Calcitonin was negative. And the urinary catecholamine metabolites, these were all very high, that are all suggestive of pheochromocytoma. And this is the CT images of native CT and the post-contrast CT showing the bilateral tumors, and the MIBG scintigraphy showing the uptake of the isotope in both tumors. Now, just as a little bit of entertainment, I would like to ask Sandra to share a poll, not a very difficult poll.
Peter, it is launched the poll, so the audience can select one of the answers.
Thank you. I don't see it, but I hope that everything goes fine.
Peter, I now also shared the results of the poll. I'm not sure if you can see it.
Unfortunately not.
Okay, I will tell you. 5% selected answer number A, severe blood pressure elevation. B, 27%. C, 9%. D, 5%. And answer E, 55%.
Okay, thank you very much. 55%, if I remember well, my question that I unfortunately do not see now was the combination of two answers. So what is the basis for when should we perform, what are the clues why we should perform a genetic diagnosis in this case? We don't have any familial history in this case, and the patient could not report any clear family member with suggestive of genetic disease. But if we asked her about her family, that is a rather large family, about five sisters of her mother died suddenly, and therefore we cannot exclude that they had pheochromocytoma, but there is absolutely no evidence. The high blood pressure the patient experienced is not suggestive of a genetic disease, because there is in the blood pressure is not different in sporadic or genetic cases. That depends in part on the secretion of the catecholamines. There is a mild parathyroid hormone elevation in the patient, and that is a very important clue. And the most important clue is the bilateral appearance of the tumors that is very suggestive of hereditary disease. So the combination of this other hormonal alteration and the elevation of the parathyroid hormone and the bilateral nature of this tumor are very suggestive of a hereditary disease. And in fact, this lady turned out to have a multiple endocrine neoplasia type 2 syndrome. And interestingly, no significant elevation of calcitonin was found at this stage, despite medullary thyroid cancer, represented by elevated calcitonin, is the most characteristic feature or the most penetrant feature of multiple endocrine neoplasia type 2. Just look at another case, a 48-year-old woman who had an intensive chest pain. She had suspicion for acute myocardial infarction, and the ECG showed ST elevation in the lateral leads. An urgent coronarography was done with the suspicion of an ST elevation myocardial infarction, but it was negative. and echocardiography revealed this inverse Takotsubo cardiomyopathy. This Takotsubo is a Japanese tool for catching octopus, and a similar morphology of the heart can occur. And one of the causes of this Takotsubo cardiomyopathy is excessive catecholamine release. So this patient was found to have a negative coronarogram, but a Takotsubo cardiomyopathy, and therefore a further examination was performed that revealed a mass in the left suprarenal region. Computed tomography confirmed an inhomogeneous tumor, and the metanephrines in the urine, as the metabolites of catecholamines, were also significantly elevated. She has been operated laparoscopically. This has been a sporadic case without any genetic background. We certainly did the genetic analysis. Now we should look at the symptoms of pheochromocytoma, and the most common symptoms are the first three: headache, palpitation, and sweating. These are certainly non-specific signs. Other signs include pale skin, malaise, flushing, weight loss due to the catecholamine metabolic activity. Psychiatric symptoms, panic syndrome can occur, and it is also important that panic syndrome is one of the major differential diagnostic modalities in pheochromocytoma. Hyperglycemia can occur due to the glucose elevating action of catecholamines. I'll come back a little bit later to this. And if we regard hypertension, the most typical form of hypertension is the paroxysmal hypertension, as shown in the first case: very high blood pressure very rapidly, but in the meantime the patient has normal blood pressure, or even it can be absolutely normal. However, this is the most typical form, the paroxysmal hypertension. The most common form is permanent hypertension, and an orthostatic hypotension might also occur, mostly in dopamine-producing tumors. Head and neck paragangliomas, on the other hand, usually do not sign shows of catecholamine excess, and often quite no symptoms can be seen in many cases. These can be discovered accidentally on images. Tinnitus and some neurological signs can occur in some cases. I have mentioned the Takotsubo cardiomyopathy as an acute sign of pheochromocytoma, but it should be mentioned that pheochromocytoma can also lead to hypertrophic and dilated cardiomyopathy. And this is a very important case, as in a case with an unknown etiology of cardiomyopathy, pheochromocytoma should be investigated. What are then the indications for screening for pheochromocytoma? This is a little bit extensive list, but I would say that it would, I consider that it is important to represent these points. Young hypertensive patient as a secondary hypertension should be investigated. Paroxysmal or treatment refractory hypertension, certainly in a case of treatment refractory hypertension, the primary aldosteronism is also indicated, or also in a young hypertensive patient. Severe blood pressure variability, severe blood pressure elevation, or even hypotension during an anesthesia, surgical intervention, or angiography. Shock of unknown etiology, a possibility of a hereditary syndrome. In all cases of adrenal incidentaloma, especially in those where the Hounsfield unit density is over 10, because that represents that it is not most of fat, and therefore the possibility of pheochromocytoma should be raised. Also, cardiomyopathy of unknown etiology. And then I have added a 10th point that I read in a recent review from Jacques Lenders, that young lean individuals with diabetes mellitus type 1, with or even without signs of catecholamine excess, should be investigated for pheochromocytoma. That is in line with the point that in about 40% of cases we see blood or sugar hyperglycemia in pheochromocytoma patients. Regarding the differential diagnosis of pheochromocytoma, many endocrine diseases should be considered, as hyperthyroidism. Carcinoid syndrome is listed here, but it usually doesn't lead to severe blood pressure elevation. In carcinoid crisis, rather low blood pressure is seen, but it can lead to flushing. Hypoglycemia can also lead to sweating, but high blood pressure is not characteristic either. Perimenopause should be highlighted along with panic syndrome. This is one of the most common clinical cases that can resemble pheochromocytoma, and patients are sent to endocrine consultations who eventually only have perimenopause or panic attacks. There are some other rare diseases, for example, mastocytosis. Cardiovascular abnormalities can lead to similar symptoms, neurologic diseases, but usually these can be easily differentiated. As the major point of our topic is the genetics of pheochromocytoma, I would like to shortly discuss the hereditary forms linked to pheochromocytoma. And the most common, most important 4 diseases are listed first. And then we have many more novel genes where there is not yet clear whether these are associated with syndromes. But for example, in the case of MAX, a recent study raised the possibility of also an endocrine syndrome. First, I would like to start with the common diseases. These are the major susceptibility genes, like the von Hippel-Lindau, the RET in multiple endocrine neoplasia, NF1 in neurofibromatosis, a large group of succinate dehydrogenase genes or gene units. And if we classify these genes that are associated to different pathways, a very novel study from Fishbein from the United States established 4 major molecular pathways in pheochromocytoma. 2 of these have already well been established. These are called the cluster 1 and cluster 2 tumors. In cluster 1, we see pseudohypoxia that is associated with the hypoxia-inducible factor 2 alpha, 1 alpha. And in the cluster 2, we see increased RAS and mTOR signaling that is mostly seen in MEN2 and NF1, but also TMEM mutations, and MAX belongs to this group. Pseudohypoxia is mostly seen in the succinate dehydrogenase and VHL mutations. There is also a novel group of molecular pathways that is associated with the Wnt-Hedgehog pathway, and there is a cortical admixture type of tumors, but the most important clusters, that is the cluster 1, that is seen with the 6-succinate dehydrogenase and VHL, and the cluster 2, that is with the increased RAS MAP kinase signaling, that is seen with MEN2, TMEM, and neurofibromatosis type 1. If we look at the prevalence of germline pathogenic variants in pheochromocytoma, we see that these same diseases have the highest prevalence, again, among the hereditary forms, like neurofibromatosis type 1, RET, SDH mutations, mostly among paragangliomas, VHL 4 to 7%. And now I'd like to turn to these diseases in one by one. MEN2, and that has been the disease of the first case I have shown. That is a rare disease, the classical multiple endocrine neoplasia type 2, that has medullary thyroid cancer as its most prevalent, most penetrant manifestation, pheochromocytoma in 40 to 50%, and primary hyperparathyroidism in 20 to 30%. There is also familial medullary thyroid cancer and some special forms. In MEN2B, we have a very aggressive form of medullary thyroid cancer that has a very high penetrance of 100%, pheochromocytoma in about 50% of cases. And there are also some special features of MEN2B, including merphenoid appearance, mucosal urinomas, intestinal ganglia neuromatosis. This is a Hungarian MEN2A family, where the grandmother had pheochromocytoma at the age of 40 and 2 years later medullary thyroid cancer. Her daughter had medullary thyroid cancer already at the age of 25, that has been metastatic already at the diagnosis, but she's still alive 21 years after the operation, and she had 10 years later bilateral pheochromocytoma that has been operated, and she's free of pheochromocytoma. The daughter has been free of disease, so we didn't have to perform a prophylactic thyroidectomy to prevent medullary thyroid cancer. In another family, the index patient had pheochromocytoma, then medullary thyroid cancer. Her mother was operated for pheo, and then she had thyroidectomy because of medullary thyroid cancer, and died of metastatic pheochromocytoma that is very rare in MEN2. One of the sons of the index patient had positive genetic testing. So the genetic screening of a family is of extreme importance. And because of the positive RET mutation, a prophylactic thyroidectomy has been performed to prevent the appearance of medullary thyroid cancer. He has been negative for pheochromocytoma at that time, but has to be followed up. And this is multiple endocrine neoplasia type 2 with these mucosal urinomas. A very special appearance of the patients are seen. And just some very interesting aspect of this patient. You see, this is the bowel of the patient that is herniated to the thorax. It is very much enlarged, and this is caused by the intestinal ganglia neuromatosis in MEN2B. Actually, a megacolon has been the result, and we see bilateral pheochromocytoma by an MIBG SPECT CT. Von Hippel-Lindau syndrome is also a special and very classic form of hereditary pheochromocytoma. We have type 1 and type 2. Pheochromocytoma is only seen in type 2. In 2C, there is only pheochromocytoma. Beside this, central nervous system, here mostly cerebellar hemangioblastomas, retinal angiomas, renal cysts, pancreatic cysts, and tumors are seen. This is a bilateral pheochromocytoma here, and a bilateral kidney tumor in a patient. Certainly, it has a very severe. It is a very severe case with not too favorable prognosis. Neurofibromatosis type 1, in contrast to MEN2 and VHL, is much more frequent. It is the most frequent hereditary tumor syndrome of solid tumors, autosomal dominantly inherited, as all of these syndromes mostly. We see special café-au-lait spots, neurofibromas, several different tumors, pheochromocytoma in approximately 5%, and a very large gene, the neurofibromin gene, is responsible to neurofibromatosis. These are the neurofibromas, a café-au-lait spot, and we see also hamartomas on the iris. These are called the Lisch nodules. Hereditary paraganglioma syndromes are the syndrome associated with the mutations encoding subunits for the succinate dehydrogenase gene. And this is the first human tumor where when the mutations of a gene with a mitochondrial function have been associated with human tumor formation. This gene is involved, the product of this gene is involved in the mitochondrial respiratory chain, but it is encoded by the genome and not by the mitochondrial genome. There are 4 main forms. As a paraganglioma, not in the adrenal, it is mostly associated with noradrenaline production. In PGL1, SDHD mutations, we see mostly head and neck paragangliomas. For example, here, a bilateral glomus caroticum tumor that is rare even on one side, but here we see in a bilateral form, so it is most probable to be of hereditary origin. Adrenal pheo is in about 25% of cases. Here we see an adrenal pheochromocytoma, and in the same patient, a thoracal paraganglioma. The inheritance pattern of SDHD is very interesting, although it is also an autosomal dominant disease. But if you look at this family tree, you can see that even if this woman is sick, his son is only a carrier. But the son of his son, so his grandson, is again ill. This man has a ill daughter, but both of the from the three children of this woman, only 2 are carriers but not ill. How is this possible? This is because the SDHD gene is maternally imprinted, and therefore the genomic imprinting means that the 2 alleles inherited from the father and the mother do not behave in the same way. One is expressed and the other is not. So you can the patients can only acquire the disease if this is inherited from the father. But if it is inherited from the mother, the offspring will only be a carrier. But from the carrier, if the carrier is male, his children will be able to develop the disease. So it is a very interesting genetic phenomenon. This is an SDHB mutation that is not maternally imprinted, that is autosomal dominantly inherited, just to show a very interesting clinical phenotype of the disease. This young boy had the symptom of collapsing during every urination, and a prevesical paraganglioma was found. And it can be hypothesized that the pressure changes during urination led to the release of catecholamines that have led to the collapse. We know that about 40% of pheochromocytomas are related to genetic background. When to perform genetic screening in pheochromocytoma patients? The current guidelines suggest that we should perform this in any case. 40% is quite high. The possibility of a tumor syndrome may predispose to other tumors, and recurrence is more probable. There is also, but nowadays not recommended, a targeted screening in the populations where the chance for hereditary disease is especially high, like in young patients, children, bilateral, multifocal tumors, or extra-adrenal disease, or association of other tumors. But currently, we propose genetic screening in any case with pheochromocytoma. I would like to turn to the diagnosis regarding pheochromocytoma diagnosis, and this is a figure showing the metabolism of catecholamines. The major metabolites are normetanephrine, metanephrine, and the 3-methoxytyramine. For the biochemical diagnosis of pheochromocytoma, we can use the urine, deconjugated of 3-metanephrines or the 3-methoxytyramine, or plasma, 3-metanephrines of 3-methoxytyramine, and we can also measure the general neuroendocrine tumor marker, chromogranin A. But for the diagnosis of pheochromocytoma, the metanephrine demonstration is pivotal. We should be aware that the patient should be prepared for the catecholamine measurements. Sympathomimetics should be avoided. Drugs should be omitted that can affect catecholamine measurements that are shown here, with like antidepressants, MEO inhibitors. Caffeine-containing beverages should be avoided. Plasma should be taken after a 30 minutes rest. Urine collection is a little bit more complicated, 24 hours in a dark bottle, stored at a cool place, and the pH should be acidic. The measurement of the catecholamine metabolites is nowadays with liquid chromatography and tandem mass spectrometry. If we look at the sensitivity and specificity data for plasma and urine, these are quite high. The highest is, however, for plasma. So this is currently the most sensitive way of pheochromocytoma diagnosis. I have to admit that at our center, we usually do the urinary metanephrine analysis because it is easier to perform for us than the plasma. The catecholamine metabolites can be useful for differentiating the different forms of pheochromocytoma in metastatic PPGL, dopamine and 3-methoxytyramine, and 3-methoxytyramine can be a marker of metastatic pheochromocytoma. Most VHL and SDH do not secrete adrenaline. That is mostly seen in MEN2 and NF1. So based on the spectrum of catecholamine metabolites, the type, the genetic background can also be a bit suspected, but certainly the genetic analysis should be done independent of this. There is a test that is called Clonidin for assessing mild normetanephrine increase. We see many cases in which the normetanephrine is mildly elevated, but we have to stress that for the suspicion of pheochromocytoma, the normetanephrine levels should be 2-3 times higher than the upper normal value. So a mild elevation of these catecholamines is not a real sign of pheochromocytoma. Clonidin inhibits the neuronal noradrenaline secretion, and if after clonidin administration that will switch out the sympathetic overactivity, normetanephrine normalizes, then it is not a pheochromocytoma. I would like to continue with the imaging diagnosis. Pheochromocytomas are rather large, so in many cases the ultrasound can see the tumors, as in our 2 cases. CT is very important, and the Hounsfield unit over 10 is characteristic for a Pheo. MRI is also good. In T2, we see a very intensive signal. Very important is the biological, the functional diagnosis. MIBG is an analog of noradrenaline that is taken up. Somatostatin receptors are expressed on pheochromocytoma, so this functional imaging is very important. And PET-CT with special tracers like fluorodopa or hydroxyephedrine. Nowadays, the best is considered to be gallium dotatate, Dotatok. But we have fluorodeoxyglucose can also be used in some cases because pheochromocytomas can have intensive glycolysis. This is an MRI showing intensive signal at T2, an MIBG SPECT-CT in a malignant paraganglioma. I'll show these figures again later. That is post-treatment with a lutetium dotatate, that is somatostatin-based imaging. In a most recent review, the sensitivities of different modalities were compared, and the gallium somatostatin-based dotatate, PET-CT, was identified to have the highest sensitivity for detecting pheochromocytoma. This is a proposed clinical algorithm for nuclear imaging. In sporadic pheochromocytoma, FDOPA or MIBG. In hereditary pheochromocytoma, FDOPA is proposed first, and in extraadrenal tumors, the gallium DOTA-based somatostatin analog. So that was the diagnosis, and if you permit, I would continue and finish my talk with the treatment. Pheochromocytoma should be removed if the diagnosis is made, certainly if it is not a metastatic disease where it is not possible anymore. The patient must be pre-treated for surgery, and the alpha blockers are the most important medications. We have 2 major alpha blockers, the irreversible antagonist, non-competitive phenoxybenzamin, that actually has only this indication as pheochromocytoma, and competitive reversible inhibitors that are also used as second-line treatments in hypertension, like doxazosine, that is not that effective as phenoxybalsamine. Beta blockers are important because patients have tachycardia, but it is very important that you should never use a beta blocker alone without alpha blockers. That is mostly valid for non-selective beta blockers, as beta blockers can block the beta-2 receptors on vessels that are responsible for vasodilatation. And if we give a beta blocker without alpha blockers, this can lead during the catecholamine release to severe vasoconstriction and thereby severe blood pressure elevation. So beta blockers are important, but only together and ideally after the launching of alpha blocker therapy. Other antihypertensive like calcium channel blockers and AC inhibitors can also be given. Pheochromocytoma is a lifelong disease because as histology cannot tell whether a pheochromocytoma is benign or malignant, but metastasis can occur even 10 years after the removal of the pheochromocytoma. This is a special situation that despite most pheochromocytomas are actually non-metastatic and thus benign, we should consider all pheochromocytomas as potentially malignant and should be followed up. It is not decided, but at least for 10 years, whether to follow up later in some cases, like in extraadrenal pheochromocytoma, or there in a hereditary disease or a large tumor, it can be proposed that a lifelong follow-up should be done with annual normetanephrine measurements. I'd like to show a case of a metastatic abdominal paraganglioma, a 50-year-old man with abdominal discomfort that has been resected, and the histological analysis showed a paraganglioma. 3 years later, the patient had tumor recurrence and multiple metastases, but not a severe hypertension. We can see why the patient didn't have severe hypertension, because he had only a normetanephrine elevation and not the metanephrine that are the degradation products of adrenaline. So it is a paraganglioma and not the typical symptoms of adrenaline overproduction are seen. Genetic diagnosis has been negative. Then he had the recurrent paraganglioma resected and had an MIBG treatment. So in this case, we give MIBG not as diagnostic, but as a therapy. He had also lung metastases that regressed after MIBG and CGA normalized. 1 year later, progressed again, and he received another MIBG treatment. But this time it was not associated with further regression. Then the classical combination systemic chemotherapy with CVD was started, but unfortunately further progression was noted, and the lutetium-dotatate treatment was done in Basel, Switzerland. Then further progression, and then therefore capacitabine temozolomide was tried with 6 cycles, but unfortunately again further progression, and therefore sunitinib as a TKI inhibitor was given. Unfortunately again further progression was noted, and now we are for a repeated MIBG treatment. This is a SPECT CT after the lutetium-dotatate. So the treatment of metastatic malignant pheochromocytoma paraganglioma is actually summarized in this case. Very important, and first line is isotope therapy with either MIBG or lutetium-dotatate. Medical treatment is based on CVD, that is the classical cyclophosphamide vincristine-dacarbazine chemotherapy. Novel agents, most important is temozolomide, that is actually related to dacarbazine. And there are reports, although there are absolutely no studies supporting that somatostatin analog in low-risk cases can be given alone. targeted therapies are investigated. Sunitinib is the one where here we have most data. The recommended first-line treatment options are the lutetium dotatate or the MIBG, depending on for which isotope is the tumor more avid. In low proliferative activity tumors, temozolomide, and in high proliferative activity tumors, the CVD chemotherapy is currently proposed. This is a classical case of a VHL patient treated with sunitinib. Sunitinib is known to have indications in kidney cancer, also in pancreatic and neuroendocrine tumors, and we see a reduction in size in kidney, pancreas, NET, and also in a metastatic pheochromocytoma. This shows a proposed treatment algorithm, actually the same as before. If we see a rapid progression of metastatic pheo, then mostly CVD should be given. With moderate progression, the radionuclide therapies are of first choice, and then are the other possibilities, the sunitinib, temozolomide, and all these converge, and we can change to the other arm if the progression is changing. Also, in a very recent review, the lutetium dotatate was identified as the most efficacious therapy treatment modality in metastatic pheochromocytoma, but we see that there are other treatments, so the differences are not that large, and the number of patients already treated with lutetium dotatate, or the reports, is not very high. Many ongoing clinical investigations are present for metastatic PPGL, and we hope that other medications will be available because, as we see, it is not a tumor that is easy to treat with the medical therapies. I would like to conclude, and many thanks. This is not advertisement, but many figures I have taken are from this book, Practical Clinical Endocrinology, that has been published this year by Springer. And I would like to thank for your kind attention, and I hope that I have given some useful information about pheochromocytoma. Second question, where would you refer young doctors to regarding treatment guidelines? I would suggest the European Society of Endocrinology guidelines. There is a guideline for follow-up of pheochromocytoma, and there is also a guideline on combined adrenocortical cancer and malignant metastatic pheochromocytoma. That is an ESMO guideline. These are freely open access available. So you can find these by simple search, but there are the European guidelines I found on the European Society of Endocrinology site. In patients with MEN2A, when do you start screening for pheochromocytoma in the, unfortunately, I cannot see the end of the question.
If you select, Peter, Peter, if you select the question, you can see the whole question.
Oh, I see. In patients with MEN2A, when do you start screening for pheo in the immediate relatives? Thank you very much. First, the question is, when do you make the genetic screening? First, the genetic screening should be done because the screening for pheochromocytoma should only be done in patients who are positive for RET mutation. That is quite variable. We have also quite variable families with where the pheochromocytoma appeared in at quite different ages. Usually, you must begin with medullary thyroid cancer screening, but in our experience, we begin pheochromocytoma screening in young adults. Another question. adrenal pheochromocytoma of 6 cm discovered as incidentaloma was hormonally silent. Unfortunately, that can happen. I haven't mentioned that because silent pheochromocytoma is a major issue. There is no hormonal sign, and even the catecholamine was negative in this case. Only CGA was elevated. In some cases, we also have such a peculiar constellation. Do you have any idea of frequency? Unfortunately not. I cannot tell how such a silent pheochromocytoma is observed, but it is usually very rare. Most pheochromocytomas have some symptoms, or at least we see some elevation in catecholamines, but that is also a question if we discover a small pheochromocytoma, and it is quite often that small pheochromocytomas are not represented by elevated catecholamine issues. So it is, I have forgotten to mention one thing, because 2 of my patients recently have been diagnosed with pheochromocytoma after adrenal biopsy, and we can also only be grateful that they survived this intervention. And one of these was a small pheochromocytoma. So there is no room for adrenal biopsy in the diagnosis of pheochromocytoma. Another question, do you recommend treatment for malignant pheochromocytoma who is asymptomatic with controlled blood pressure? Is active surveillance maybe an option? Yes, active surveillance can be an option. It is also included in the reviews I have presented. Not everybody needs to be treated. For example, if it is a slowly growing, stable disease, then active surveillance is quite acceptable. You mentioned SDHD mutation. Yes, that's correct. That is very rare. Yes, you are right. Yes, SDHD exists, but it is an extremely rare condition. Yes, you are quite right. There are many genes that are involved in pheochromocytoma as susceptibility genes. SDHA is a relatively novel among the SDH genes. I mean novel, it is known for more than 10 years already, but there are only very few cases with SDHA mutation. That's, yes. The question is, adrenal pheos in SDH are more likely to be silent. That can be correct because they mostly don't secrete adrenaline, even if they are adrenal tumors. I don't know the mechanism, but in VHL and in SDH, we usually do not see adrenal secretion even from the adrenal. Very glad that I was here and also glad that you were here. It has been a pleasure for me to make this webinar, and I hope that I could be helpful in your acquaintance with this disease, and I hope that I have provided some useful information for you in the field of this very interesting and fascinating tumor as pheochromocytoma is. Thank you very much.